Good morning. On behalf of the Congress of Neurological Surgeons, as the current Vice Chair of its international division, it's a distinct pleasure and a great honor to introduce Professor Shinichi Yoshimura. Professor Yoshimura is the President of the Japanese Neurosurgical Congress, an organization with which CNS has a long and proud tradition of cooperation. Professor Yoshimura serves as the Professor and Chair of the Department of Neurological Surgery at Hyogo College of Medicine. He's also the current president of the Japanese Society of Neuroendovascular Therapy. Professor Yoshimura is an internationally known and respected neurological surgeon. In his current position, he has made a number of very significant and important contributions to vascular and endovascular neurosurgery, both in Japan and elsewhere. His contributions to the stroke literature are significant, with over 100 articles in this area alone. Professor Yoshimura has made a number of contributions to organized neurosurgery as well. The scope of these contributions are very visible internationally. So he has served on the board of Japanese Neurosurgical Congress and the Japanese Society for Neuroendovascular Therapy since 2009, and as both societies' education chair for a number of years. He also serves as the chief editor of Japan Neuroendovascular Therapy and is a counselor of the Japanese Stroke Society. Professor Yoshimura, your presence at this meeting of the CNS in San Diego builds further on the strong ties between our two organizations and illustrates the spirit of internationalism inherent in both of our organizations. It's a real honor to welcome you here in San Diego, and we eagerly look forward to listening to your presentation.
Thank you for kind introduction. I'm Dr. Yoshimura from Japan. I'd like to show the highlight of this year's annual meeting on behalf of Japanese CNS. This is my COI. This is a brochure of our annual meeting. The theme of our meeting was Art and Science of Neurosurgery. We had more than 4,000 participants. Professor Lonser kindly visited us and to make a special lecture regarding von Hippel-Lindau disease. Thank you, Professor Lonser. Your talk was wonderful. Let me introduce some topics of our annual meeting. First one is brain-machine interface by Professor Yoshimura from Osaka University. They implanted the electrode in the brain for the patient suffering from ALS. It was when it went on air, so please look at the video.
Hideaki Tachibana is 61. 6 years ago, he was diagnosed with ALS. His only functioning muscles are those moving his eyes and lips. Tachibana was keen to take part in the trials. His condition is worsening, so he wants to see practical application of this new technology developed fast. 90 days after the surgery, the first test started. This is a moment of truth for the new system. The first step is to see if Tachibana can control this robotic arm.
Grip the ball. Yes, you're doing well. Now release it.
After a lot of practice, Tachibana is finally able to move the robotic arm with 80% accuracy.
It is still on clinical trial, but we are looking forward to more application of this technique to the human after appropriate modification. Our next topic is establishment of the evidence regarding bypass surgery for hemorrhagic Moyamoya disease. We know that the bypass for Moyamoya disease is effective to prevent ischemia. However, is it preventive for hemorrhage? To answer this question, Professor Miyamoto from Kyoto University started the JAM trial. It is multi-center prospective randomized control trials to know the preventive effect of direct EC-IC bypass on intracranial rebleeding of adult hemorrhagic myomed disease. Study took a long time, including planning. It took more than 14 years. But after this trial, they got wonderful results. Bypass surgery reduced the adverse event from 34% to 14% significantly. And also, bypass surgery reduced rebleeding from 31% to 11% significantly. So they established the evidence regarding EC-IC bypass effect on preventive effect, rebleeding. The third one is surgery for brainstem tumors. Professor Saito from Tokyo University showed wonderful 3D imaging, pre-operative simulation of brain tumor removal. We could know the relationship between nerve, vessels, and also tract like this. In another case with hemangioblastoma, they beautifully demonstrated feeder, tumor, and drainer, and reconfirmed it by ICG intraoperatively. Based on these findings, they first clipped 3 feeders, and afterwards they coagulated them and cut and carefully divided the tumors from brainstem, and like this, and finally they removed the tumor in an en bloc fashion, like this wonderful operation. So lastly, I'd like to show our own topics regarding carotid artery stenosis. There are 2 ways to revascularize the stenosis in case of a carotid artery, endoarterectomy, and also stenting like this. In Japan, these 2 treatments done by neurosurgeon, major players are us. And compared to surgery, stenting is more frequently performed like this. However, a recent meta-analysis of our CTs reported that CA is superior in terms of stroke or death rate like this. So we should decrease these complications in case of CAS. I'd like to show the problems of filter-protected CAS. In this patient, after deployment of the stent, there was no problem. But after post-dilatation, vessel suddenly occluded. The patient got restless. So we aspirated and captured the filter. And the patient was fine, but cognitive dysfunction remained due to multiple infarction like this. So when we look at the filter, a lot of debris and thrombus were there. So what is the cause of distal embolism after filter protective CAS? It was debris released from the plaque when the plaque has a large amount of soft component like this, lipid core or hematoma like this. In that case, we believe CA is better because we can get rid of entire plaque. However, we sometimes should perform stenting. In that case, we need better protection device and stent. We can diagnose soft plaque before the treatment by time-of-flight MRA, regular MRA. If we see high-intensity area in the plaque, it means the plaque has large amount of hematoma. So after knowing this, we selected CA for the patient with his positive plaque on MRA. This part was treated by CA. We compared these two periods. Previously, we performed mainly stenting for the patient. And the selection of more CA for soft plaque decreased the stroke after carotid revascularization dramatically like this. So we wanted to know what was going on in this group. To know that, we applied optic coherence tomography for carotid artery to know the plaque status after stenting. This is a typical case of the patient treated by regular stent for soft plaque. We could see the stent strut and guide wire like this, and also the protruded plaque like this through the stent strut. It may lead to the distal embolism. So recently, a micromesh covered stent was released from Europe, and we started clinical trial with this and performed same examination with OCT. This is a rough stent, and the stent has another micromesh like this. Look at this, there is no protrusion of the plaque inside. So this new device may change the indication of stenting for the patient with soft plaque. So highlights of this year's annual meeting of Japanese CNS were introduced. New technology and devices are changing our treatment rapidly. Thank you for inviting me to your CNS, and we wish to deepen our friendship between the two countries. Thank you for your attention. Thank you.
Thank you very much.
Oh, thank you. Thank you so much.